Hello everyone, Kia ora. I'm Hamima. So I'm from the Heat Care at SEACO project, which is the heat adaptation through community-based approaches and research at the SEACO Health and Demographic Surveillance System in Malaysia, from National University Malaysia. And today I will share some of our field experience in evaluating a physiological marker within a community-based trial. So let me introduce you to the Heat Care project, which is currently being conducted in Segamat, a district which is located in the southern part of Malaysia. And Segamat has experienced an increasing numbers of heat wave events in recent years. So the Heat Care project aims to implement community-based intervention to protect the communities from the health impacts of heat using the SEACO Health and Demographic Surveillance System platform. So this study utilizes a 2x2 factorial design in a randomized control trial where we have randomly selected 884 participants or households introducing the cool roof intervention, which is similarly like HAPVIA, the UV reflective paint on the roof, but we also introduced the behavioral intervention to protect themselves from the impact of heat. And consequently, we will follow up the participants at 3, 6, and 12 months after the interventions through surveys, physical measurements, and wearable devices, as well as switchboard meter that measures indoor temperature and humidity level. So beyond designing these interventions, one of our major challenges is to assess the effectiveness of the intervention, especially using a meaningful clinical measure in a community setting. One of the key measures that we have selected is glycated hemoglobin, or HbA1c, that measures the average blood glucose level over the past 2 to 3 months. And it is also a diagnostic test for diabetes and an indicator of long-term glucose control. So this choice is especially relevant to Malaysia because Malaysia has the highest diabetes prevalence in Southeast Asia, and diabetes accounts for the largest share in terms of direct healthcare costs in the country. And we know that people with diabetes, they also have impaired physiological responses to heat stress. For example, impaired sweating and vasodilation, which then can further increases their vulnerability during hot weather. So therefore, HbA1c provides a valuable endpoint in evaluating whether our intervention contributes to better health outcomes in this vulnerable population. However, implementing HbA1c as a point-of-care test in the field came with major challenges, because the device we used was highly heat sensitive. So it will malfunction at indoor temperature of above 32 degrees Celsius and required a stable power supply. And in our study site in Segamat area, where most homes have zinc roofs, and as you can see in this figure, the mean indoor temperature during the afternoon can reach around 33 degrees Celsius, and in some cases even up to 38 degrees Celsius. So this created interruptions during data collection and then placing an additional burden not only to participants, because of the test had to be repeated. Even though the community valued the HbA1c testing, access remained limited, as you know that the test is typically available only in town-based clinics, and travel costs might be the barrier for many people. To address these challenges, we took several practical steps. So we began monitoring the indoor temperatures of these homes and identify the optimal testing times, and then reschedule HbA1c measurements, specifically only the HbA1c measurement during cooler hours in the morning. And then when necessary, participants were invited to the study site, which in some cases it can go up to 1 hour of car ride, with transport arrangements or mileage claims provided. And we also ensured participants to receive their health check results and referral slips. Of note, we also measured blood pressure, random blood glucose, and anthropometric measurements, which the participants greatly appreciated. And despite these adjustments, challenges remain because rescheduling often required multiple household visits. Travel logistics were demanding for both participants and field staff. And we learned that the device constraint in hot climates can significantly affect data collection and community engagement. And looking forward, we can see a clear need for more heat-resilient diagnostic tools, possibly with better built-in cooling system or portable power options that can make such interventions scalable and sustainable. And to summarize, HbA1c remains essential for diagnosing diabetes and assessing long-term glucose control, and with practical adjustments like temperature monitoring, rescheduling, and transport support can greatly improve feasibility in real-world field conditions. And persistent environmental and logistical barriers remind us of the need for more climate-adapted diagnostic solutions. And finally, HbA1c serves as both a clinical and policy-relevant outcome that can link health research directly to real-world action. So with that, I thank you all for your attention.
Thank you.